Hello and welcome. I'm Dr. David Minter. I'm here to assist you with your critical thinking for IM 660. Today we're going to be talking about a case of diabetic ketoacidosis. So we're going to talk about some of the basic differential diagnosis for abdominal pain. We're going to talk about how a patient presents in DKA. We're going to talk about causes of diabetic ketoacidosis, and then we're going to talk about how to look at a workup under various clinical circumstances. Then we're going to talk about how to treat this. First off, we're going to start with a practice question, the answer of which is all the way at the end of the video. So without further ado, let's get started.
A 35-year-old male with a history of type 1 diabetes mellitus presents to the emergency department with nausea, vomiting, abdominal pain, and rapid, deep breathing. He reports missing several insulin doses over the past week due to financial constraints. On examination, he is tachycardic and tachypneic with dry mucous membranes. Laboratory studies reveal the following: glucose 780 mg per deciliter, sodium 136 millimole per liter, corrected 148 millimole per liter, potassium 5.2 millimole per liter, bicarbonate 10 millimole per liter, anion gap 28 millimole per liter, pH 7.21. Which of the following is the most appropriate initial treatment for this patient? A. Intravenous bicarbonate therapy. B. Intravenous fluid resuscitation. C. Intravenous insulin infusion. D. Oral sodium bicarbonate. E. Subcutaneous rapid-acting insulin.
Chief complaint: my stomach hurts and I can't stop vomiting. Case is a 42-year-old male, presents to the emergency department with nausea, vomiting, abdominal pain for the last 8 hours. Over the last few days, he's been more fatigued and weaker with decreased appetite. His abdominal pain began this morning and was followed by 5 to 10 episodes of non-bloody, non-bilious vomiting. He has not been able to tolerate water and is very thirsty. He denies any fever or diarrhea upon questioning. He does have some mild shortness of breath and is feeling a little confused. He has a past medical history of type 1 diabetes, hypertension, and hyperlipidemia. Surgical history is only positive for a wisdom tooth extraction. Social history: he's a non-smoker, occasional alcohol, and uses THC. His family history of hypertension, diabetes mellitus, and MI. His current medication list includes Glargine, which is Lantus, 20 units at bedtime, insulin aspart, which is Novolog, 5 to 10 units with meals, lisinopril 10 milligrams daily, hydrochlorothiazide 25 milligrams daily, and atorvastatin 10 milligrams daily. He has a blood pressure of 110/68, heart rate 115, respirations 28, oxygen 97%, on room air, temperature of 98.7. He's in moderate distress, alert but confused. He's got some dry mucosal membranes. Cardiovascular exam shows some tachycardia with regular rhythm. Respirations clear bilaterally with some mild tachypnea. His abdomen soft with mild epigastric tenderness, no guarding or rebound. Patient's alert but slightly delayed in responses. No focal neurological deficits noted. Extremities show no edema with +2 pulses bilaterally. So let's start with the differential diagnosis for this patient. He's presenting with abdominal pain and nausea and vomiting. So depending on where the area of the pain is, we can consider some gastric causes of this, such as PUD, gastritis. The patient is diabetic, so things like gastroparesis jump higher under differential diagnosis. Cyclic vomiting, since the patient uses THC, would also be in consideration. We could consider some biliary and liver causes like acute hepatitis, any obstruction from choledocholithiasis or cholecystitis could cause abdominal pain. Pancreatitis can also cause abdominal pain. Intestinal causes would include things like enteritis, colitis, specific infections like diverticulitis. There can be functional changes in the bowel, leading to things like ileus and obstruction that cause abdominal pain and vomiting. Ischemia or decreased blood flow to the intestines would cause this. Stepping outside of the GI causes, but other intra-abdominal causes would be things like pyelonephritis, obstructive kidney stones, urinary tract infection. More specific to women would be things like pelvic inflammatory disease, ovarian torsion, or men, also still torsion, but testicular in this case. One of the interesting things about our patient and talking about a differential diagnosis for abdominal pain is people get focused on the abdomen without thinking of non-GI causes or non-intra-abdominal causes of abdominal pain. And now we start to move into some of the endocrine causes, which would be things like diabetic ketoacidosis. Adrenal insufficiency can also cause this. Thyroid disease can also cause abdominal pain. More zebra causes would be like hereditary angioedema or possibly anaphylaxis, withdrawal, things from like opiate withdrawal or alcohol withdrawal can all cause abdominal pain, and then some more advanced things like porphyria or abdominal migraine. So if the nurse came in and did an check and then said it's too high to read, well, that kind of makes the diagnosis for us. Somebody's complaining of abdominal pain, vomiting with a blood sugar that's off the charts. Frequently, when you see patients with diabetic ketoacidosis, the diagnosis will be quite obvious by their physical exam as being coupled with the incredibly high blood sugar they might have. Since we're already pretty sure about the diagnosis being diabetic ketoacidosis, we didn't have the blood sugar right out of the gate. We could have asked some specific questions relating to hyperglycemia. Polyuria, polydipsia, polyphagia are all associated with just elevated blood sugars. That might tell us the patient's been running less controlled before getting the check. But since we're pretty sure about the diagnosis, we should ask some more specific questions as to why do they have DKA today? What happened to them? What's changed? So the two most common causes for diabetic ketoacidosis would be noncompliance and infection. So noncompliance, there's a relative insulin deficiency. So that one's kind of obvious. You're not doing anything to control your blood sugars. They go higher and higher. You start not utilizing glucose any longer. You start breaking down fats and producing acid. Noncompliance is one of the most common causes of it. It's the number one, I believe. Infection is going to be number two, which is stress on the body is an easier way to think about it. So there's a surge in counter-regulatory hormones that result in hyperglycemia. So outside of infection, anything else that puts significant stress on the body can also have this counter-regulatory surge. So other things would be like if they just got into a traumatic accident, if they broke a femur, if they had a myocardial infarction, if they just had a new stroke. Other things that can cause counter-regulatory hormones would be sympathomimetic drugs, so amphetamines, cocaine. Some medications that can also induce diabetic ketoacidosis would be steroids most commonly, but other things like hydrochlorothiazide could do this. So looking over the patient's medication list, we should probably ask about if the HCTZ is new or old. So what do we make of our physical exam and what other things should we be looking for? Well, when working on the original differential diagnosis, we should probably look for the specific location of the abdominal pain. If it's epigastric, that tends to, and diffuse, that tends to be more diabetic ketoacidosis. We should probably take a closer look at their breathing. The patient has tachypnea. They were noted to be breathing fast on exam, but we should look at the specific pattern of breathing that the patient has. Tachypnea just means that the rate is elevated. It doesn't necessarily mean the breathing is any deeper. Hyperventilation is deep and fast breathing. And Kussmaul breathing is a specific form of hyperventilation that's associated with metabolic acidosis, in this case because of ketoacids. I do get questions every once in a while about Sheehan-Stokes breathing and how this differs. Sheehan-Stokes is rapid breathing followed by periods of slow breathing or apnea. Other things we should look for in physical exam is why did this patient have diabetic ketoacidosis today, and how's my physical exam going to help me with that? So uh, I should look for signs of hemiparesis, and I should look for signs of infection. So if I had somebody with very lower abdominal pain that really didn't match anybody else that I'd seen with DKA in the past, then maybe I'd want to do some imaging of the abdomen. If I'm listening to their lungs and I hear a crackle at their left base, then maybe I'd want to order a chest X-ray for pneumonia, or if they have specific flank pain when I tap on one side, meaning looking for pyelonephritis. Should look in their throat. I should look in their ears. Should ask about sinus pain. I should look at all their skin to make sure they don't have a cellulitis. So what is some initial treatment we would want to start on this patient while we're doing some information gathering? So we'd want to order some testing, but while we're doing that, the nurse is going to put an IV in. We would probably want to start them on some high-dose boluses of isotonic saline. So we already know they're hyperglycemic. They've already been vomiting, so clinically we can ascertain that they're dehydrated, so we should give them volume back. I don't necessarily want to do anything about the hyperglycemia yet because we want to make the diagnosis of DKA. So even if the blood sugar is registering super high, we can kind of put a pin in that and swing back to it when we get some other labs. Otherwise, we'd probably want to treat their symptoms. The patient's having nausea and vomiting, so maybe I'd want to give them some aldosterone or Zofran, 4 milligrams IV. I probably want to keep them comfortable and treat the pain that they're having in their abdomen. So maybe I'd give them 4 to 8 milligrams of morphine IV, which is a standard dose for an adult patient. And speaking of workup, what workup should we order for this patient? Kind of starts with lab work. We'd want to do a complete blood count, looking at the patient's white blood cell count. They're frequently elevated in patients with diabetic ketoacidosis just from the stress of the disease process. Specifically, looking at bandemia can sometimes be helpful to tease out a possible underlying infection. We'd want to order a basic metabolic panel looking at the patient's acid base status with their bicarbonate. We should usually expect it to be low, meaning there's a metabolic acidosis. We'd want to look for specific electrolyte changes, either anticipated or that might interrupt treatment, which I'll talk about in a little bit. We'd want to look at the patient's kidney function too, as these patients tend to be pre-renal and dehydrated. We could order a urinalysis that would help us with ketones. The specific gravity might talk about the hydration status of the patient, but like I said, we pretty much know they're dehydrated. We could confirm sources of acidosis with an acetoacetate level or a beta hydroxybutyrate level. Hospitals differ in which one they check between one emergency room or hospital to another. We might want to check a blood gas on the patient. This can be venous or arterial. Most patients get a venous check as arterial blood gases are pretty painful, and venous levels differ only slightly from arterial. So if you understand how to interpret them, they can give you pretty much the same results in this case. For example, the venous pH runs a little lower in there's like 7.31 to 7.41. The O2, since it's already been extracted, runs 35 to 40 with a saturation of 70 to 75%. And bicarbonate's about the same between arterial and venous, but the PaCO2 actually runs a little higher in venous blood at 41 to 51. Okay, let's look at some lab results for our patient. Starting with the CBC, we see that elevated white blood cell count, sometimes that can mean stress or infection, as I said. Hemoglobin is a touch low, and in this case, it's actually hemoconcentrated, given the dehydration of the patient. So tomorrow, when they get rechecked, I'm expecting that hemoglobin to probably drop more. So they have an underlying anemia. Platelets, nothing remarkable there. It's kind of on the high end of normal, so likely reactive secondary to the diabetic ketoacidosis. When we look at our basic metabolic panel, we're going to look at the anion gap first. So this is your chloride plus your bicarbonate, and then that is taken away from your sodium. So in our case, it's 129 minus 92 plus 8, which comes out to an anion gap of 29, which is significantly elevated. When we look at the patient's sodium level, it's 129, so that's low. But that's expected. I would anticipate a patient having a low sodium, and this is secondary to pseudo hyponatremia, secondary to the elevated blood sugar that they have. We can correct this with the math that's listed here, showing that the patient actually has a normal sodium of 141. Our potassium is elevated at 5.5. Again, this is to be expected. It's falsely high, secondary to transcellular shift from the acidosis. The patient's actual total body potassium is way down due to the osmotic diuresis that they've had from the elevated sugars for X amount of time. So patients tend to have, are low in potassium to the tune of hundreds of milliequivalents. So this 5.5 potassium level is not going to stay elevated once we begin our treatment. Looking at the patient's BUN to creatinine ratio, we can see one that's greater than 20 to 1, which is again anticipated. They have a slight acute kidney injury, assuming that this is not their baseline creatinine level. Let's take another example. Let's look at a second basic metabolic panel. So sodium in this patient's 140, potassium's 3.2, chloride 115, bicarbonate 10, BUN's 44, creatinine's 3.8. So their bicarb isn't quite as bad. So maybe you would think, oh, their labs aren't as off. Actually, some of them are in the normal range. So you might make the mistake of looking at this and thinking, oh, this person's in less trouble. But starting with the sodium, if we actually do that corrective math again, we can see that the patient's actually hypernatremic. So they're more dehydrated. They've had more free water loss from osmotic diuresis. So they're actually in worse shape, even though their sodium level is pointing to something benign. Their potassium level, 3.2, that's just a little bit below normal, but wait, the acidosis and transcellular shift it should be falsely elevating this. So that means as soon as I take away the acidosis in this patient, their potassium is going to plummet, and they'd be high risk for developing an arrhythmia. When we look at the BRN to creatinine ratio, now we can see that it's no longer 20 to 1. So pre-renal causes are the most common cause of acute kidney injury. This patient has had free water losses from osmotic diuresis, so I would expect them to have a 20 to 1 ratio. But what happens when this has gone on long enough is this BRN to creatinine ratio starts to narrow and it becomes less than 20 to 1, indicating that the patient may have acute tubular necrosis from the overall hypovolemia. So what treatment and monitoring is needed in diabetic ketoacidosis? Well, first we're going to start with some IV fluid replacement. Generally, this begins with fluid boluses, 20 cc's per kilogram to start, and then a high fluid rate of 250 cc's per hour. Generally, this happens where they'll receive 2 to 3 liters in the emergency department before being started on a high maintenance fluid. These patients tend to be approximately 6 to 9 liters down total, with about 50% goal to be replaced in the first 12 hours, and then the rest replaced over the 24 to 36 hours total. Although the admission time for patients with diabetic ketoacidosis is about a day. So even though these patients may come in with terrible looking labs, writhing in pain, they've got a bicarb of 4 on their blood work, and you think they're really in a lot of trouble, these patients turn around quite quickly and can generally be discharged in 24 hours. For maintenance fluid, we're going to add, usually with isotonic zero point 0.9 normal saline, you can add 20 to 40 milliequivalents of potassium in each one of these bags if the potassium level is less than 5.3 initially. If the patients had, for some reason, they were the second case where they have a significant hypernatremia, then you can use 0.45 normal saline instead of zero point 0.9 saline as to not worsen the hypernatremia, because in that case, the person just needs more free water than they do isotonic fluid. We monitor this by looking at the patient's hemodynamics. So we titrate this to their heart rate and to their blood pressure and to urine output, and then physical exam changes like them having moist mucosa. Next, we're going to want to start them on a regular insulin drip to increase glucose utilization and decrease ketone production. This would start with some patients get bolused regular insulin to start with. Some patients get started on just a higher rate of drip, but usually it involves about a unit per kilogram to start with. So if you have a 70-kilogram patient, you're going to start them on an insulin drip of about 7 units per hour. You're going to titrate this to changes of about 50 to 75 drop in glucose for every hour. And lots of different hospitals have lots of different protocols about this. Like Cerner and Epic have different protocols that are just built into titrating your insulin drip. Different written protocols are written in ICUs based on what your intensivist wants. There's lots of different ways to do this, but just generally you're looking for a nice slow descent of 50 to 75 an hour. Titrating this drip, if they're not meeting that goals, then you're going to titrate the insulin up. If they're dropping too fast, then you're going to titrate the insulin down. We do not initiate an insulin drip initially on patients if their potassium is less than 3.3. And why? Is because that increased glucose utilization and drop in ketone production that happens by initiating insulin is going to cause a whole bunch of transcellular shift as glucose moves into cells, as well as that decreased ketone production gets rid of the acidosis. So those are the two main driving factors that's keeping the potassium up. So if the potassium's low, you initiate insulin on them, then they can drop further and the patient may be at risk for respiratory failure from weakness or arrhythmia, actually more likely. To monitor the insulin drip, we're going to do Q1-hour AccuChecks. And then as the patient's their serum glucose drops over time, we're going to add some dextrose to the IV fluid. So this, depending on if it's diabetic ketoacidosis or HHS, this generally happens around a serum sugar level of 250 milligrams per deciliter. At that point, you're going to want to change the IV fluid over to half normal saline. It's a little bit less chloride because patients tend to end up with a hyperchloremia and a non-metabolic acidosis when the treatment's all done. And the added sugar to the intravenous fluid kind of helps slow the descent of the sugar. So what is the way I analogize this is when you start somebody on an insulin drip, their sugar is going to drop quite significantly. You're going to be monitoring it every hour to make sure it's not dropping too quickly and titrating the insulin down. When you start to get closer to 250, 200, the person's going to start to get at risk for hyperglycemia or hypoglycemia. If your insulin's running too fast, your sugar might drop suddenly 100 in an hour. So adding the dextrose to the IV fluid is like pulling the parachute in a free fall. So it just helps slow that descent of the sugar so the patient doesn't end up with a complication of hypoglycemia. Next, we're going to mine the electrolytes. This involves Q4-hour electrolyte levels. One point of this is looking at the patient's anion gap. The other point is to monitor the patient's potassium as it drops. When the anion gap is gone completely and a bicarb level of less than 15 is greater than 15 is generally when we stop an insulin drip. In practice, in most of the places I've worked in, they usually repeat this times 2, meaning that you have 2 sets of blood work or 2 sets of electrolyte panels that show a non-anion gap and the bicarb being greater than 15 before discontinuation. The reason can be sometimes in practice, if we stop it a little too quick, the person might slip back into diabetic ketoacidosis and prolong their hospital stay. At some point, we should probably check a phosphorus too. Hyperphosphatemia generally is seen with the acidosis initially, but the patients tend to be overall hypophosphatemic, much like potassium. So we should probably check one of those during their stay and replace as needed. Bicarbonate therapy. Now, this is kind of a controversial subject. They've studied this and they found you would think that if the patient's having such a severe metabolic acidosis that you would want to treat them with bicarb, but they found that it has no benefit with a pH level of greater than 6.9, and it hasn't really been studied very much in a pH of less than 6.9, so they can't really prove how helpful it is. So the guidelines recommend that if you have a pH of less than 6.9, that you should initiate intravenous bicarb therapy in as an IV fluid. Again, lots of hospitals do this differently, and then they've made some recommendations about it's like 2 amps and 500 cc's over 2 hours, and then repeating a pH. And if it's greater than 6.9, then you can discontinue the bicarbonate therapy. So they're just saying that if it's less than 6.9 your pH, then maybe they would benefit from bicarb, but when they're over 6.9, then this is a treatment you would want to discontinue. And then treating the underlying cause. So this is probably one of the most important aspects of this. So if it's medical noncompliance, you're going to want to talk to the patient about why that is. Do they need further education and instruction about insulin therapy? Is there an insurance issue about why they're not able to afford their medications? Do they need somebody else set up at home to come in and monitor them to make sure that they're not slipping up and they're taking their medications as needed? And then other more interesting etiologies of diabetic ketoacidosis and exacerbation would be they have infections or MIs. So it's some ER doctors in practice will order an EKG on every single patient that comes in with DKA. You can really titrate this to what you find on the patient. So the patient that's breathing fast, that's been having nausea and vomiting, then maybe teasing out in their history, asking them a little bit more about like, okay, what was the first symptom you had with this? Were you having chest pain and then shortness of breath, and then a few hours later you were vomiting? And that kind of went away, because then that might make you think more that the patient had an MI. Or if the patient's having a fever at home and then nausea and vomiting and abdominal pain, then maybe we'd want to look for an intra-abdominal cause. So it just depends on the patient, but lots of people kind of skip looking into the underlying cause. This is an easy diagnosis to make. Type 1 diabetic comes in, abdominal pain, vomiting with high blood sugar. I mean, the diagnosis is almost made for you at that presentation, but it's real important to look into what the underlying cause may be.
Correct answer. B. Intravenous fluid resuscitation. This patient has DKA, as evidenced by severe hyperglycemia, high anion gap metabolic acidosis, and ketosis. The most immediate life-threatening issue in DKA, dehydration due to osmotic diuresis. Intravenous fluid resuscitation with normal saline is the first step in treatment to restore perfusion and reduce hyperglycemia. Insulin therapy is initiated after initial fluid resuscitation to avoid rapid shifts in osmolality that could precipitate complications like cerebral edema. Bicarbonate therapy is rarely indicated in DKA unless pH is less than 6.9. Subcutaneous insulin is not appropriate for acute management.